patient in United States of America or in UAE. So the trigger can be varied. So initially what happens, initially there will be like large and small airways which is constricted and which becomes edematous. And then later on there will be fatigue and respiratory failure setting in for our patients. So there is episodic evening worsening of all parameters like symptoms, airway inflammation. As you can see in this slide, the airway inflammation, the hypertrophy of the smooth muscles, what you can see. And the key in management of asthmatic patients is early identification and appropriate recognition of severity. So how will you assess our patient? So rapid assessment in ER is crucial. So brief history, we need to understand the baseline status of the patient, severity of the symptoms, what medication patient is on, any comorbidities, previous ER visits. We need to assess the patient clinically by assessment of the respiratory rate, accessory muscle use, level of consciousness. So all this becomes handy, and we need to evaluate with necessary investigation. And we have a whole lot of armamentarium of tests like peak expiratory flow, X-rays, SpO2, blood gas analysis, ECG. All these things are handy for our patients. So severity assessment you can done with whatever modality your institution has, and we make use of an assess severity clinically as well as by looking at the parameters of oxygenation and carbon dioxide levels as well. So we need to identify the severe and the life-threatening situation. I remembering the days where the clinician comes in the college days, they comes and auscultate the patient. Clinically, they detect the pulsus paradoxus, or they find a silent chest, which tells you the patient is in imminent danger. There are types of asthma exacerbations, which could be the type 1, which is more common, which has a female predominance, as you know that, which is triggered by an infection and less responsive to therapy. And then you have the type 2, which is more common in males, which is more severe and more triggered by inhalation of allergens, and which is more responsive to therapy as well. There's a cardiopulmonary sequelae for any asthmatics. So as the work of breathing increases, what happens is there is hyperinflation, as we know, which can lead towards what is called an intrinsic PEEP, which can in turn lead to a decrease in venous return to the right side of the heart, high intrathoracic pressure, which cause increased afterload to the heart, exaggeration of the difference in blood pressure, which we clinically find as a pulsus paradox. There's a direct mechanical compression of the heart and coronary arteries, which can in turn lead to myocardial ischemia. So all these is a cascade of events which happens in our asthmatic patient. Blood gas analysis is necessary sometimes in ICU settings, in ER settings. We look at usually oxygenation problem is because of ventilation perfusion mismatch. And it's usually the oxygenation asthmatics do respond to oxygen therapy. And we do find patients having pseudo-normalization of carbon dioxide. That's like usually these patients, we expect the carbon dioxide to be little on the lower side because they wash out. But if you find that the PCO2 levels is normalizing, you have to think that this is a bad sign. So pseudo-normalization of PCO2, you have to be considering as a bad sign. So we have to find the features of an impending respiratory failure from the history, whether the patient has previous intubations, patient has many hospitalizations before, whether he is elderly, any psychosocial, long smoking history, educational status, patient has any signs and symptoms such as a pseudo-normalization of in the carbon dioxide in the blood gas, peak expiratory flow, persistent peak expiratory flow less than 40%, there's no response to bronchodilator therapy. All this becomes handy for our patients. It's going to another question. Does our patients, asthmatic patients, they do really die? So there is a concern that 1 to 2 per 100,000 patients do die unless you give them the proper care. And asphyxia due to excessive mucus plugging or the drug side effects could be the reason for them to die in the intensive care unit as well. So we have a whole lot of medications. We have short-acting bronchial agonists, long-acting bronchial agonists to treat our asthmatic patients. We have anticholinergic. We have long-acting muscarinic antagonists as a treatment modality. There has been guidelines on how we deliver the medications. So there are actually MDIs, DPIs, and nebulizers we have available. There have been a lot of debates has happened on the loss of this medication because in the GI tract, in the apparatus, and so on. So don't think that you are giving a medication through a specific device. You're going to deliver the complete delivery of the drug to the terminal alveolus, but you really need to get these medicines into. Most of them can get loss during the when you really give this medication to the patients. So now the industry is trying to make newer and newer devices, which has looking at many factors like as plume velocity, plume temperature, and the technique of delivery. So all those things are evolving day by day in the smart approach in delivery of medications. Steroids plays a major role in the treatment. So there has been debates on how much, which route, and how soon we need to use and how long we need to use this medication. There's always a need for inhaled steroids, and we do use injectables and injectable and oral forms of steroids in our asthmatic patients. Oxygen has a role, and the goal should be to keep a saturation around 92%. And one thing we should not forget is that hyperoxia is detrimental for our patient. Administration of 100% oxygen for a long time is not. Probably it can be problematic because it's released hypoxic vasoconstriction, which can be regional effect, which can be detrimental for our patients. There has been use of theophylline and other medications like magnesium, which is used for refractory bronchospasm. We do use leukotriene and antagonists in our clinical practice. So we have a whole lot of medications to use in our clinical practice for treatment of asthmatic patients. And biologics also is a new class of medication which has come up and which is being used widely in the practice. Antibiotics sometimes recur if the patient has associated bacterial infection as well. This is how the medications, what we have it in our armamentarium to treat our asthmatic patients. So let's go to our area of interest. So the talk which we have today is what is new in GINA in 2022. So each year I told you this GINA, Global Initiative Asthma, the guidelines get revised every year. We have the European Respiratory Society and the Thoracic Society of the US as well. So the guidelines get updated and collaborate each other in patient care to get a proper and advanced patient care and a good outcome for our patients. So GINA 2022, they look at the fact like achieving and maintaining a better symptom control for our patient and target reduction of future risk of exacerbations. So there's a recommendation to assessment of symptom control by a questionnaire, like whether in the last 4 weeks the patient had any daytime symptoms, which is more than twice per week, any night waking up due to asthma, whether the patient has short-acting bronchodilator reliever needed more than twice per week, any activity limitation due to asthma. All these questionnaires were asked, and the level of asthma were assessed whether well-controlled, partially controlled, or uncontrolled based on these questionnaires. And then we have the risk factors for poor asthma outcome as well, in which there's a risk factors for exacerbation for asthmatic, which include having more than one severe exacerbation in the last 12 months, or the patient having a chronic sinusitis, obesity, gastroesophageal reflux disease, or the patient has been ever intubated or in intensive care for asthma treatment, or whether have high SABA use. All these things are actually risk factors for exacerbation. Then you have risk factors for fixed airflow limitation, which is like patient is not taking any inhaled corticosteroid treatment, asthmatic smoking habit, and occupational exposure, mucus hyper secretions. These are the risk factors for airflow limitation. And also medication side effects, like if the patient is a frequent oral steroid use, high dose potent ICS misuse. So these things you have to keep in mind when you're treating our patients. Definition of asthma, severity, and there has been discussion on the severity of asthma in the new guidelines. Generally, we consider the concept of mild asthma. Mild asthma is actually defined in the current guidelines as asthma that is well controlled on low dose ICS or as needed only ICS formoterol. The GINA 2022 recommends against the use of mild asthma because the utility and relevance of the definition is much less clear. The mild asthma, the term is often interpreted very differently by clinicians, and many clinicians and the patients as well assume that the mild asthma means no risk and no need for controlled therapy, which is actually a problem for our patients because up to 30% of the asthma deaths are in patients with infrequent symptoms. So, which we have to keep in mind that we need to understand even the mild asthma need to be addressed. By the ATS ERS task for definition, asthma severity is assessed retrospectively from the treatment required to control the patient's asthma. So by definition, severe asthma is asthma that remains uncontrolled despite optimized treatment with high-dose ICS LABA or that require the high-dose ICS LABA to prevent them from being uncontrolled. So the definition is important, and also difficult to treat asthma is that it's difficult to treat because of the poor adherence or because the inhaler technique by the patient and the patient associated comorbidities. So this definitions becomes more revolutionized as in the coming days in GINA updated guidelines. So in this, you know that in GINA 2021, you have the step 1 to 2, step 3, 4, and 5, and the requirement of all these inhaled corticosteroids and short-acting bronchial agonists and LABA has been mentioned in the guidelines. The current guidelines say that there is two-track approach. The track 1, which is the low-dose ICS formoterol as a reliever, it is a preferred approach, and the track 2 is an alternative approach with SABA as a reliever. If the track 1 is not possible or is not preferred by the patient with no exacerbation on their current therapy. So this is one of the characteristic guideline change which come up in the GINA guidelines. If you look at from GINA 2021 and 2022, there has been description of use of a specific molecule called anti-TSLP. Anti-TSLP, I will come to that, is a biological agent which has been recommended for severe asthma management. So I'll come to that in the biological session in a short while. So there has been other, so the track 1 and track 2 I have mentioned. So track 1, which is the ICS formoterol, is a preferred approach because SABA reliever, because of the reduced risk of exacerbation compared with the SABA reliever with the similar symptom control and lung function. That's the main reason why this guideline has been adopted. And there are other control options like you can know leukotriene inhibitors, but the thing is that the efficacy and safety, the evidence is less strong than these two regimens. In step 5, a new class anti-TSLP, which has a biological therapy has been incorporated. I'll come to that in a while. So in GINA 2022, short-acting bronchial agonist is no longer the preferred reliever. And for safety, GINA no longer recommends treatment with SABA alone. Whenever a SABA, short-acting bronchial agonist, is given, you need to make sure that patient is taking an inhaler therapy as well, steroid inhaler therapy as well. And overuse of SABA is associated with the increased risk of severe exacerbation. And there has been study looking at the number of canisters and which can lead on to increase the number of canisters, increase mortality as well. So if you look at the complete approach, the MD SMART, medium dose SMART therapy, is the highest evidence in asthma management compared to any modality of short-acting bronchial agonist therapy add-on to inhaled forms of steroids. There are changes in the asthma at a glance in GINA, ATS, and ERS. So there are some of the salient features I will mention. The two-track approach I mentioned, the low-dose ICS formoterol as a reliever, definition of severe asthma without reference to GINA steps. So whether you're 1, 2, 3, 4, 5, doesn't matter whether they are severe. Definition of severe is different. There has been recommendation on the looking at the peripheral eosinophil count if the initial value is low for deciding biologics. So this is important for the patients. because there sometimes patients on treatment with smart therapy, MD smart therapy, they find that their local eosinophil counts changes. So there may be a chance that this patient may be beneficial with the use of biological agents. So we need to recheck peripheral eosinophil count if initial value is low for deciding biologics. This is very important, they have mentioned. And also I mentioned about the vitamin D level, which should be checked and corrected if pregnancy to reduce the risk of early life wheezing episodes. There are, we know that we do low, medium, high dose different ICS in the clinical practice. For example, fluticasone propionate, which is 500 milligram high dose, and budesonide 800 milligram, we do high dose. So, but what the guideline now say is that this is not a table of equivalence. These are suggested total daily doses for low, medium, and high dose treatment options with different ICS, but you cannot equate a 500 milligram of fluticasone to 800 milligram of budesonide. This is another important factor which has been mentioned. There has been mentioning about the asthma control questionnaire, the preference of using questionnaire 5 instead of 6 and 7, and also mention about withholding time of bronchodilator therapy updated to ATS spirometry guidelines. That is SABA 4 hours, twice daily LABA 24 hours, and daily LABA for almost 36 hours. So these are the updated guidelines which came up in 2022 in GINA asthma management. So look at what GINA has to tell in COVID-19 and asthma management. This was interesting because there are some facts which came up. So far, I was thinking that in my concept that asthma is a concern for COVID situations. But there has been study that people with asthma do not appear to be at increased risk of acquiring COVID-19. And systemic reviews have not shown an increased risk of severe COVID-19 in people with well-controlled mild to moderate asthma. So is there any asthma has an increased risk of COVID-19 related deaths? But the studies, overall studies have shown that there is no increased risk of COVID-19 related death. And in one meta-analysis, mortality appeared to be lower than the people without asthma. So this was something interesting to understand, because being an asthmatic, that your COVID-19 related death is not going to be a problem at all. It's not a staggering issue. There is implication for asthma management, and the guideline recommend you need to adequately control asthma management, adequately control, you have to control and take your medications properly. And there has been many countries saw a decrease in incidence of asthma exacerbations and influenza-related illnesses, possibly because of the healthcare measures such as the hand washing, mask, social distance. All this probably must have helped in COVID-19 related deaths and COVID illnesses to be coming down as well. If you look at the use of vaccine, people with severe allergic reaction to COVID-19 related ingredients, for example, polyethylene glycol for Pfizer or Moderna, or in the polysorbate 80 for AstraZeneca, you need to see that, and a different vaccine need to be given. And we need to make sure that all asthmatic patients get the updated COVID-19 and sufficient dosing of vaccination to protect our patients. So this is mandatory as well. There are other changes, clarification to use written asthma action plans. Acute asthma healthcare setting, at salbutamol still the preferred molecule. Formoterol, there are some studies have showed similar efficacy and safety in emergency department studies. And one study even showed a high dose of budesonide formoterol has similar efficacy and safety as SABA as well. There's a use of air filters which can reduce the particle exposure, but no consistent effect on asthma outcomes as well. And use of e-cigarettes is associated with increased risk of respiratory symptoms and asthma exacerbations. So this is in nutshell about the GINA and its related topics to COVID-19. So let's discuss some facts. Do clinicians contribute to global warming? It's an interesting fact I noticed. Global warming potential of current and future inhalers. So there's a carbon footprint for inhalers. not just inhale, whatever we use in our daily life, there is a carbon footprint. So there is global warming potential propellants used in different inhalers. You know, the older generation has CFCs, and the new generation has hydrofluoroalkanes or HFAs. So it has been shown that the newer ones are better than the older ones because CFC are having very high carbon footprint. So it's going to another question, whether which is the most preferred mode for our clinical practice, whether MDA, DPAs, or the softness inhalers are should be used in our clinical practice. It's interesting to know that DPA has no propellants. If you look at the Ventolin Evohaler and Ventolin Accuhaler, it's like equivalent to a car traveling at 175 miles per hour compared to 4 miles per hour in an DPA inhaler. So dry-power devices are more beneficial to climate. They have a 20 grams CO2 equivalent per dose compared to MDA, which is almost 500 grams. So this is a concern, and which is something interesting data which I come across. Let's go to the biologics of the future. The tezepelumab is the upstream blocker, which is a thymic, which acts on the thymic stroma lymphopoietin, which is an alarming cytokine. So compared to the other molecule like dupilumab, mepolizumab, benralizumab, and omalizumab, this is an upstream blocker. So now because basically other molecules acting on IgE or interleukins, if you do an upstream blocking, it's found to be more beneficial for the asthmatic patient in blocking the pathways. Let's look at this factor. Can CT scan predict the lung function decline and exacerbation in asthmatic patients? There have been studies looking at the wall thickness and area, hyperinflation, air trapping, point-based change in the lung volumes like quantitative CT metrics. They have looked and found that more severe remodeling and hyperinflation in CT findings in adult patients with future lung function decline, and also future rate of exacerbations in CT is seen when you find more of CT findings of severe airway remodeling and small airway disease. So this was interesting. Can commensal virons predict asthma severity? This is another study where they looked at when you find healthy and asthmatic lung, they found how high prevalence of HSV-CME and Epstein-Barr virus. So they looked at the asthma severity, lung function, and asthma exacerbation in these patients. They found that if you look at the viruses and the bacteriophages in the lung, there is a significant association with viromes and clinical variabilities of asthma severity. And herpes virus and bacteriophages from airway have a potential future application as a biomarker for asthma. An asthmatic had high risk for developing cancer. This interesting study from Boston, which looked at more than 75,000 patients, they found that the cancer incidence was higher, 6 to 10, 6 in non-asthmatic to 10 in asthmatic, with a hazard ratio of 1.7. With asthma incident development was associated with increased risk of subsequent cancer development. So interestingly to note that it's not just lung cancer, there are bladder, hematological, pancreatic, stomach, liver, and other cancers were all common in asthmatic, not just the lung cancer. Our patient is still in the ICU, still in the emergency department. We given our patient, just going back to our patient now. So our patient is still in the emergency department. We are giving the patient oxygen, short-acting bronchodilators, steroids we are given, and we reassess at the end of 1 hour. So where are we now? What we noticed that our patient became more tired, unable to perform the maneuvers, becoming more drowsy, pulses paradox is not appreciable, CO2 retention is noticing, so he's getting tired out. This is where we have to really look into help of our intensive care colleagues. So there's a need for assisted mechanical ventilation, non-invasive ventilation, or mechanical ventilation. So we need to assess our patient closely, take into account multiple parameters, respiratory rate, mental status, hemodynamic stability, and also any change in oxygenation. We have to look at the magnitude of change from baseline, acuteness of change from baseline, and promptness of response to initial therapy. So NIV, non-invasive ventilation, has a role to play in a short duration. Maybe you have to try for a short duration, but if you get results, you can continue that. If you're not getting results, you may have to look for invasive machines. So the prospective studies have looked at NIV in severe asthma. They found that decreased risk ventotracheal intubations and early initiation of assisted ventilation. So ventilating in asthma, when you go for invasive ventilation, it's pretty a nightmare for any intensivist because of the complexity involved in the management. And we need to understand the mechanics. The predominant site of airway resistance, as we know, is in asthmatic in large airways. There is subepithelial fibrosis, propensity to develop severe airway limitation, and gas trapping, the so-called the autopy. So intubating asthmatic patients is trickier. You need to give proper pre-ops, avoiding neuromuscular agents, minimal manipulations, large bore endotracheal tube, avoid vigorous ventilation after intubation. All those becomes mandatory. We need to understand the mechanism of autopy because of the increased respiratory rate, airway obstruction, dynamic airway collapse, and the patient is ventilating with large tidal volumes and the shorter expiratory time. Many factors plays a role. Development of the supra-atmospheric alveolar pressure at the end expiration, which can result in dramatic clinical consequence. There can be phasic variations in asthmatic length, varying severity of obstruction, varying alveolar time constants, varying end expiratory volumes and pressures, and varying volumes of tidal gas pressures. So there is a concern on the mechanism of autopy development, and which is actually has a consequence, which is in the form of respiratory compromise. There's an increased work of breathing, and there is hemodynamic compromise in the form of cardiac output dropping, hypotension. And if your patient is on lines, you can have an overestimation or underestimation of compliance as well. So ultimately, what leads to is like increased mortality if you don't address this autopy actively in our patients. So recognition is important. You need to understand whether the patient has effort to trigger any unexplained patient agitation, hemodynamic compromise, missed efforts. We need to look at the flow time graphs, and you need to look and measure the expiratory halt, which is actually, we can find the flow time curve with the autopy development, which is the norm. As you can see in this graph, the normal versus the asthmatic length, where you see the where you can see the autopy is developing. So it becomes handy, and you use the measurement called the expiratory halt maneuver to understand this autopy development. And you need to do treatment modalities like manipulating ventilatory settings, like increasing in expiratory time, decreasing respiratory rate, using large bore endotracheal tubes, decreasing ventilatory demands like treating infections, counter the effect of autopy by application of external PEEP. This becomes mandatory for managing autopy. So the patient has been intubated, connected to the ventilator. She has severe spasm. Autopy, you put all the settings in and you are managing the patients. So you need to set the ventilator. So you need to, obviously, you need to know that how to ventilate the patient. You need to use adequate sedation modes, adequate baseline settings, and you need to look at the plateau pressure and the peak pressure of the patient to show where the patient exactly sitting in terms of the airway pressure which is developing in the lungs. We have to use maneuvers like reducing inspiratory time, reducing respiratory rate, permissive hypercapnia, all those maneuvers to optimize the ventilation. And at the same time, we need to use PEEP, which is which avoid critical airway closure, and which applicate almost like magnitude, which is almost 60 to 80% of the autopy, which is very essential because sometimes the expiratory halt maneuvers can overestimate because not all the airways are communicated towards the terminal, because there can be obstruction by different levels in the asthmatic lengths. So which can be very well explained by a waterfall analog, where you need to really understand the pressures like alveolar pressure, critical pressure, and the airway pressure, where you need to use a PEEP just above the autopy, just to manage the autopy. So we will not have increase the work of breathing of the patient. There has been studies looked at Heliox, which is actually is a material, is a pharmacologically innate material, which is actually can decrease the resistance of airways and decrease work of breathing. But the evidence is quite not strong as well. It becomes important to use humidifiers inspired humidification of the inspired gas. You can have the conventional humidifiers or HME filters you can use in the clinical practice. We can use spacer device inline or nebulization, and this can be helpful to to make sure there can be adequate because so much of hyperventilation and also moisture to the expirate, which can drive the and cause worsen the mucus plating. So it becomes important to humidify the lungs as well. Weaning in asthma, general all the weaning principles applies. You have to look at the airway, breathing, circulation, metabolic parameters, and indexes which you are commonly using in your bedside. It's much easier in asthma than COPD. COPD becomes a little more tricky because of the complexity. And in the safe hands, you can do a good job in weaning these patients. The most important thing is to taking care of the underlying inflammation with the proper help of a pulmonologist, and also at the same time treating the bronchospasm and taking care of the spasm. So this is concept that's a baby lung concept. If the baby can walk, child can walk, the child will walk automatically. So the same way in asthmatic, once you take care of the inflammation and once you take care of the bronchospasm, it will be a road to recovery for our patient. At the same time, we need to understand the concomitant steroid use and neuromuscular uses in our ICU patients, with the hazards of critical illness polyneuropathy, which can hamper the weaning problem as well. So I will conclude my talk here with a couple of remarks. It's important in early identification and recognition of severity in asthmatic patients. And severity is assessed by rapid focused evaluation, simple signs and limited tests, and GINA assessment of the symptom control, future risk and treatment tracks should be followed in clinical practice. And decision to mechanical ventilation is based on combination of factors, as I mentioned. Is clinically you have to assess the patient, sensorium of the patients becomes very important, and also look at the numbers. Ventilation can be a nightmare, but we need to address the autopay, ensuring acceptable ventilation. We need to do the weaning using the normal weaning principles. NIV and invasive ventilation has a role to play, combined with optimal medical management. It's very important to treat the asthma. Asthma, basically the underlying inflammation and the bronchospasm need to be addressed very seriously. And we need to integrate asthma management with the broader context of planetary health. So ultimately, you need to save our globe. And if you can do with the use of inhaler therapy as well, we need to adopt in our practice. So with these remarks, I will conclude my presentation here. These are my references, and I'm open to comments, corrections, criticisms, contradictions, if any. Thank you so much for patient listening. Over to you, Dr. Hassan.
Dr. Hassan, you are mute.
Thank you, Dr. Oni, for such informative and comprehensive. You already covered, I think, from the basics to the advances of medication and management and the new guidelines of GINA. We are, I think we should all get happy from your such informative lecture. Thank you, Dr. Oni.
Thank you, Hassan.
Thank you.
Yeah, we will keep the question and answer session at the end of Dr. Neil's lecture. So, in a request to audience, if you have any questions, please post it in the Q&A tab in your screen. So, moving forward, to introduce Dr. Majdi, Dr. Neil, I invite Dr. Majdi. Dr. Majdi, please.
Yes, okay. I'm really pleased to be with you, actually. Thank you, Dr. Oni. Thank you, Dr. Hassan. Thank you, Dr. Oni, especially for this informative and prestigious presentation. Today, I will introduce Dr. Neil Levin. He is one of the famous clinical nutritionists. Actually, he is co-founder and previous director of the American Nutrition Association. He is also board certified from the International and the American Nutrition Association. He worked as director of the Mid-American Health Organization. He also involved in Now Health Group and the non-GMO project as a senior nutrition education and technical advisory board. It's a pleasure to introduce today Dr. Nell for talking to us for the interesting topic, really, role of supplement in diabetes management. The floor of you, Dr. Nell. Thank you.
Thank you, Dr. Magdi. And I'd like to thank the folks at Zuleika Hospital and Dr. Uni and all for inviting me to this presentation. And that's just a summary of my credentials. I'm going to talk about a few nutrients today: alpha lipoic acid, 2 of the B complex vitamins, B1 and B12, the berberine compound from certain herbs, chromium, magnesium, omega-3 fatty acids, probiotics, and vitamin D, and their role in diabetes. We'll start with alpha lipoic acid. It's considered the universal antioxidant because it's soluble in both fat and water, and it's a precursor of glutathione in the body, so it helps with both cellular and liver detoxification, as well as ascorbate not only absorption and recycling, but has some unique properties in diabetics. It helps with healthy insulin sensitivity and helps protect against diabetic complications, including nerve damage and kidney damage. One of the mechanisms of alpha lipoic acid is strengthening inositol's ability to improve insulin sensitivity. Inositol can also act as an insulin mimic and an insulin messenger. So inositol is one of the nutrients associated with the B complex family. It's not an actual B vitamin, but it is found in lecithin and many B complex supplements. So lipoic acid stimulates insulin production and improves the glucose utilization to reduce oxidative damage caused by high blood sugar. Helping with insulin resistance and insulin sensitivity, helps with blood sugar control. And it also helps with symptoms of diabetic neuropathy and retinopathy as well. So diabetes causes oxidative stress, and that's one of the mechanisms by which diabetes causes damage to the body. Oxidative stress has an inflammatory component, and inflammation is involved in diabetic retinopathy as well as neuropathies. Diabetic retinopathy is clearly an inflammatory disease, and alpha lipoic acid protects against diabetic neuropathy. It's considered an effective drug against certain forms of neuropathy, and it works better in patients that have good control of their sugar, good glycemic control. Long-term administration helps against diabetic retinopathy and is something that helps prevent vision loss in diabetic patients. Now, the dosing is typically between 600 and 1800 milligrams a day to reduce symptoms of peripheral neuropathy in diabetic patients. It improves numerous symptoms. Improvement tends to occur within about a month, and dosing has been used for a period of at least 6 months. When we're looking at diabetic neuropathy symptoms and pain and disability, those scores improve significantly. We're looking at about a doubling of improvement versus a placebo group. Here's a study where they looked at 3 different dosing in both Russia and Israel, and they found that an oral dose of 600 milligram once daily had the optimum risk to benefit ratio. The risk is side effects, potentially in high doses. So we're looking again at about a 50% improvement in this study on the treatment groups, and reducing the symptom score, reducing the stabbing and burning pains, and there was an increase in nausea, vomiting, and vertigo in patients doing the higher doses, which is why they recommend the 600 milligram. Now, we know that diabetics have very low levels of vitamin C in their cells, especially in their immune cells. And alpha lipoic acid improves the bioavailability of vitamin C in diabetics specifically. It boosts their glutathione levels and helps their detoxification mechanisms. And it helps to transport vitamin C into immune cells directly, as well as recycling oxidized vitamin C into the antioxidant form. Now, when we're looking at the B complex vitamins, there's two we're going to talk about today. The thiamine or vitamin B1 is the first one. Thiamine levels can be about 76% lower in type 1 diabetics than healthy volunteers, and between 50 and 75% lower with type 2 diabetics. There's a higher risk of thiamine deficiency in people with diabetes based on these tests. That's from the US National Institutes of Health. Oral supplementation between 150 and 300 milligrams a day of thiamine can decrease glucose levels in patients with type 2 diabetes or even glucose tolerance problems. Thiamine is involved in helping pyruvate get into the Krebs cycle for energy. And if you don't have enough thiamine, B1, that could be responsible for some of the cases of lactic acidosis associated with metformin use. Thiamine deficiency also tends to increase development of diabetic neuropathy. And in the diabetes, there's an increased shedding of thiamine through the kidneys that is associated with diabetic nephropathy, sorry. And thiamine supplementation can actually prevent or even reverse early stage diabetic nephropathy. Again, this high dose, they're talking about 150 to 300 milligram typically, can prevent or slow the progression of hypoglycemia towards diabetes as well, with significant improvement. And vitamin B12 is the other B vitamin that we need to talk about. It's very likely that diabetics are deficient in vitamin B12 with a number of clinical manifestation, including memory, dementia, and other types of symptoms. Metformin use is the main factor associated with vitamin B12 deficiency in type 2 diabetics. And also there's an autoimmune feature that tends to be very frequent among patients with type 1 diabetes. Type 1 diabetics tend to have autoantibodies to intrinsic factor that's responsible for active transport of vitamin B12. Now, you can absorb about 1% of oral B12 without intrinsic factor. That's why we give high doses as a supplement. Autoimmune hypothyroidism and celiac disease are frequently found in patients that have type 1 diabetes, and these affect B12 metabolism. And treatment of B12 deficiency is the same. You typically give intramuscular or oral B12 in doses of 1,000 micrograms daily for a week, and then once every week for 4 weeks will normally correct vitamin B12 deficiency. Higher doses, you'll find supplements typically going up to 10,000 units. But remember, you only absorb about 1% orally without the active transport. Active transport only moves 2 or 3 micrograms, which is a very low number. So if you take 1,000, you're only going to be absorbing 10 or 12 micrograms of that orally. That's the injection will, of course, work a little better. Vitamin B12 replacement helps with symptomatic improvement with neuropathies. With or without a B complex supplement. And there is an improvement with B12 alone, though. Now, berberine is an interesting material. It helps with glucose and lipid metabolism. It is found naturally in herbs, golden seal, Oregon graperoot, barberry. It reduces blood glucose in type 2 diabetics and might work with conventional medications as well. It works on the adenosine monophosphate activated protein kinase and inhibits gluconeogenesis and some other interesting factors. So it's involved in regulating body weight, glucose management, insulin signaling, as well as lipid metabolism. Taking berberine 500 milligrams 2 to 3 times daily for 2 to 3 months can reduce hemoglobin A1C, fasting plasma glucose, postprandial glucose in type 2 diabetics compared to placebo, may be as effective as metformin or other similar drugs. So taking berberine, usually about 1 gram to 1.5 grams per day in divided doses for 2 to 4 months, can reduce the fasting blood sugar, the postprandial blood sugar, and hemoglobin A1C. But if you combine it with oral hypoglycemic drugs, it does improve those measurements additionally compared to what the drugs alone can do. And berberine can also reduce blood lipids and is similarly effective in one meta-analysis to a statin drug. So you might get some beneficial side effects as opposed to negative side effects. Combining it with caprate, one of the medium chain triglycerides, improves solubility and can increase the area under the curve by 28% and reduce the glucose curve by 22.5%. And you can see in this chart, the area under the curve, the plasma berberine does absorb much better with caprate or caprylic acid, one of the medium chain triglycerides, and it does cross the cells lining the intestine as well. And when we're looking at the diabetes specifically, we're looking at the top line being the diabetes model group. The green line under that is the berberine alone group. The blue line under that is the berberine with caprylic acid or caprate. And then you've got a control group down below. So you see there is a significant improvement taking berberine with caprate, the medium chain triglyceride. The area under the curve is much increased. So that lowers the blood sugar, in other words. And giving berberine or metformin or combination, we're seeing the combination works better than the single therapy. Now, chromium, of course, is a mineral that's been long associated with blood sugar because it's a component of the glucose tolerance factor, along with niacin and glutathione. And it helps to make insulin more effective. It tends to have antioxidant effects as well. The U.S. Food and Nutrition Board of the National Academy of Sciences and Medicine considers chromium to be an essential nutrient based on its effects on insulin action. And this is probably the most commonly cited studies in the journal Diabetes of chromium supplementation for type 2 diabetes. Adults were given two different doses of chromium picolinate for 2 to 4 months. And the ones who received 1,000 micrograms a day of this form of chromium had significantly lower fasting serum glucose concentrations than placebo or even the 200 microgram, which is somewhat common in multiple vitamins. So we're seeing the fasting serum glucose levels being lower if they got the 1,000 micrograms a day of chromium versus placebo. We're looking at a 31 milligram per deciliter drop in serum glucose levels. We're also seeing challenges after a glucose challenge lower, 33 point lower on that scale. both doses lowered fasting insulin concentrations as well as the insulin concentrations after a glucose challenge. But you could see the 8.5 versus 7.5 versus 6.6% lower levels of hemoglobin A1C. It varied with placebo, the low dose, or the high dose, and the high dose worked the most effectively. Magnesium is also closely associated with diabetes, which a lot of physicians aren't aware of. Insulin and glucose are regulators of magnesium metabolism, is one reason. Magnesium plays a role in regulating the action of insulin and how insulin acts in the body. And insulin resistance actually goes up in patients who are magnesium deficient. Low magnesium intake and increased urinary loss are the main factors here. Low intake has been related to development of type 2 diabetes as well as metabolic syndrome. And type 2 diabetes is often associated with magnesium status problems. Magnesium deficits have been recognized in type 2 diabetic patients with poorly controlled profiles, longer duration of the disease. So these are the measurements that show what the people who are actually deficient in magnesium, 0.61 nanomoles per liter or 1.5 milligram per deciliter. But even levels of 0.75 millimoles per liter or 1.8 milligram per deciliter can be preclinical low magnesium status. Level is significantly lower in uncontrolled diabetic patients versus those with good glycemic control. And the longer duration of diabetes, the more likely the magnesium level is going to be significantly lower as well. So that's another factor as well. Diabetic older patients are more prone to have low magnesium levels. Measuring glycated hemoglobin might be a better measurement for them, the iodized magnesium. And these are the most important factors of magnesium deficits in type 2 diabetes, that diabetics are excreting more as well as not getting enough orally. And metabolic syndrome is another factor involved in magnesium deficiency. Magnesium deficiency increases insulin resistance. And magnesium intake is inversely associated with the onset of type 2 diabetes as well. Decreased risk of about 2/3 in the folks who take the most magnesium intake. So it's clinically appropriate to look for altered magnesium status in diabetic patients. Oral supplements seem to be useful to restore deficiencies, improve insulin resistance, oxidative stress, and inflammation, all important factors. Now, omega-3 fatty acids are another important nutrient. They're deficient in modern diets. You have to get them from food or supplements. The plant sources are poorly converted. Only about 5 to 15% is converted from ALA to EPA, and that's a magnesium-dependent enzyme. So you could see how that would be a factor that would affect diabetics as well. 30 to 40% of patients with diabetes will develop neuropathy. And omega-3 has a role in reducing the triggers of neuropathy, specifically proteinuria. Fish oil supplements can reduce the risk for type 2 diabetes by affecting levels of adiponectin hormone that's linked to insulin sensitivity. And that will also lower the risk for heart disease. So the anti-inflammatory action of omega-3 and the inhibition of autoimmunity are two factors that are important. For example, inflammation is something that contributes to the beta cells dysfunction and death in type 1 diabetes. Insulin sensitivity increases significantly after 8 weeks on an omega-3 diet, and the other responses trend lower, including serum C-reactive protein and a trend towards lower interleukin-6, so it can affect the inflammatory markers as well. Now, there's sufficient evidence to say that omega-3 can yield significant benefits in preventing type 1 diabetes and delaying disease progression by anti-inflammatory, antioxidant, anti-apoptotic pathways, and the suppression of autoimmunity. And supplementation also improves glycemic factors in patients with type 2 diabetes. The appropriate dose is 1,000 to 2,000 milligram a day of EPA and DHA, not total fish oil. And that improves glycemic factors, including hemoglobin A1C, insulin resistance, the HOMA-IR, and the lipid profile as well. Probiotics also have a role. Probiotics improve glucose metabolism with greater effect with a longer duration over about 2 months and multiple species. Probiotics can decrease blood glucose through improved inflammatory controls and preventing beta cell destruction. Consuming probiotics could reduce the fasting blood sugar and the hemoglobin A1C significantly. And looking at insulin sensitivity specifically, we're seeing a greater impact from multiple species of probiotics on patients with non-alcoholic fatty liver disease as well. Fasting insulin was significantly decreased with probiotic treatment compared to placebo, with no effect on the secretion of fasting insulin. And it works by several ways. It has an oxidative role. It prevents oxidative damage. And that's an important factor as well, increasing glutathione and other important antioxidant factors, reducing oxidative stress. It increases liver natural killer cells to have an anti-diabetic effect against insulin resistance as well. And lastly, we'll talk about vitamin D. Vitamin D deficiency has been associated with type 1 diabetes to increase the risk. And there's also an association with type 2 diabetes, according to the American Journal of Clinical Nutrition. Vitamin D stimulates insulin secretion. There's a receptor on pancreatic beta cells. It reduces insulin resistance and improves insulin sensitivity. And it has other effects on glucose metabolism and insulin signaling as well. That's from the US National Institutes of Health. Studies find an inverse relationship between vitamin D status and blood sugar levels in both diabetic patients and non-diabetic subjects. Patients who are overweight or obese and took 4,000 units, 100 micrograms of vitamin D for 2.5 years, showed that there was a 62% lower incidence among participants who had low baseline vitamin D levels who took the supplement than among those who took placebo. So it helped those who were low in vitamin D to avoid diabetes. Here's another meta-analysis taking 50,000 a week supplementation for 2 to 6 months versus placebo. Those taking more than 2,000 units a day who were vitamin D deficient at baseline, had good glycemic control, were not obese, and were of Middle Eastern ethnicity, had a reduced insulin resistance, a significant amount. Vitamin D deficiency reduces insulin secretion as well. Vitamin D is needed to maintain adequate blood levels of insulin as well. In the EuroDiab study, there was a 33% decreased risk of type 1 diabetes in subjects who had vitamin D supplementation. The Nurses' Health study with 84,000 nurses showed that doubling consumption from 400 to 800 units a day reduced the risk of diabetes by 13%. And a study in Finland, 10,000 children born in 1996, they were followed for 31 years. They supplemented 2,000 units a day during the first year of life, and those children had a lower risk of type 1 diabetes of 78% just by supplementing to infants. We know that vitamin D deficiency and decreased exposure to solar radiation that can create vitamin D in our skin increases the risk of type 1 diabetes and are associated with type 2 diabetes. Diabetic neuropathy is associated as well with low concentrations of vitamin D. In one study, giving 2,000 units for 3 months, it significantly improved pain by almost 50% in neuropathy. And in another study, the same dose at 3 months, they increased the serum concentrations to a normal level and associated with significantly lower pain scores. People with type 2 diabetes who have low vitamin D status are also more likely to have increased inflammation and hemoglobin A1C levels compared to those who have adequate vitamin D status. So that ends my presentation. I want to again thank the Zuleika Hospital and New Country Healthcare, and we'll turn this back to the moderator for questions.
Thank you, Dr. Nell, for this informative presentation. It's really informative. Actually, I have one question, and the board have 2 questions. It's related to one related to your presentation, and I think one not related to your presentation, but actually it's involved in the nutrition science. From my side, actually, definitely we have many studies now about probiotic use in diabetes and relation for insulin resistance. Not only diabetes, for most of the medical diseases, especially hormonal disease, including the diabetes. So you recommend specific type of the probiotic to be used in type 1 or type 2 diabetes, and there is a difference between type 1 and type 2 diabetes in the corrective microbiota of them.
Well, there will be differences in the population of microbes in people who have diseases typically. You'll find that the people who have the most number and diversity of intestinal bacteria have the best health in many areas, including diabetes. So it's not that there's a difference necessarily between type 1 and type 2, because there's different causes, often different age groups associated with that. But, and there's an autoimmune component, obviously, to type 1 diabetes. But for, when we're looking at probiotics help to minimize autoimmune problems, that could be a factor. Is the mother getting enough? Is it getting to the infant? And are the children getting enough probiotics where they're protecting their beta cells in the pancreas from type 1 diabetes, as well as getting enough vitamin D and other nutrients, which are also important. So I don't think there's necessarily a specific formula or dosing. It's just you need a good number and a good variety of probiotics in the gut to protect health, because they help protect against things from entering the intestinal wall and passing through into the bloodstream. They form a layer, a biofilm, that helps have a protective effect. And they certainly affect immunity, inflammatory signaling, and those kind of things as well, which, as we know, are all associated with risk of diabetes.
Thank you. I now transfer to the floor. There is one actually comment and a question at the same time. In spite of the studies mentioned due to lipoic acid deficiency and lipoic acid benefits, vitamin B still in the American Diabetes Association guidelines not included any statement regarding that or giving any good recommendation for using this supplement in diabetes. Do you have any comment for that?
Yeah, many of the national medical associations are extremely conservative. Many of the people on their advisory boards are not experts in nutrition. And they're not necessarily looking at all the evidence. So, when we're looking at evidence like this, we know there's clear roles for nutrients. We know oxidative damage is a feature, a hallmark of diabetes and diabetic retinopathy and neuropathies. So the damage caused by diabetes is largely oxidative and inflammatory. It is logical to take things that are antioxidant and anti-inflammatory to help control that. But they want a level of one problem is that a lot of the studies, they want a study where it's given as a drug, where it's a novel substance, it's not a nutrient. There is a bias in conventional medicine many times against natural substances that are already in the diet. And they want something that's patentable. They want something that is unique. And so they want an analog, a synthetic analog, more than a natural substance. So natural substances do not get the respect that the studies indicate that they should have. That's my opinion.
Yes. Actually, the second question is not related to your topic, but actually it is one of the interesting questions. Which types of the drug are the best solution for adult facing joint problem? I think including osteoarthritis, even for the bone cracks and leg cracks and thoracic cavity cracks.
You're wondering what is recommended for that?
Yeah, actually, no, actually, yes. What's recommended for that?
Well, one of the first things is to, again, reduce inflammatory problems. So many of the natural treatments for arthritis or joint pain or things like that are natural anti-inflammatories. Things like curcumin from turmeric would be commonly used. And there are certain forms, certain concentrations where there's very good clinical studies, reducing NSAID use, doctor visits, all the measurements you could take, the WOMAC scores, those kind of things all improve when they're taking certain supplements. And curcumin is one example. Taking glucosamine chondroitin, when I was on a television program in Chicago with doctors from Northwestern University Medical Center, their joint clinic and their pain clinics both were using glucosamine chondroitin, not for immediate pain, but for preventing the degradation of joints where the bone ends were moving closer together. The joint spacing was narrowing, and they were using it specifically because of long-term studies showing the avoidance of that space in the joint narrowing where you get bone on bone eventually, where it maintained the distance. It did not improve it, but it maintained it. And they both clinics at Northwestern University Medical Center, their representatives expressed the same idea. They used it in the clinic for that purpose.
Okay, third and last question from my side, actually, also from the floor. Please, could you give us some list of natural sources, the general tonics for essential nutrients, usually deficient for a patient at the general source? I think this is a general question. If you have any secret combination or something like that.
Well, of course, we want a healthy diet to start with. Let's use that as a base. But dietary supplements fill gaps in diets. Many people have specific dietary restrictions. And dietary restrictions almost always restrict certain nutrients. Gluten-free is a very common thing nowadays. Grains have many nutrients, vitamin E, plant sterols, fiber. There's so many components in there that if they skip that as part of their diet, what are they replacing it with? I've been a vegetarian, this is my 50th year. So there's a whole list of nutrients I have to worry about. I have to worry about B12, protein, omega-3, copper, zinc, iron. It's actually a long list of things that are of concern. And so every time there's a restricted diet, and people have their own dietary preferences as well as medical needs for special diets that restrict what they eat and focus it on certain things, I usually will recommend a multivitamin to bridge many nutritional gaps. I take a multivitamin myself. I take a handful of pills, and I take alpha lipoic acid. I take extra vitamin D. I take a lot of these things. I take extra magnesium 3 times a day, but I'm building that on top of a multivitamin. So I get most of my B vitamins in the multivitamin. I get my copper and zinc in the multivitamin. I'm getting in the diet too, but the multivitamin's a good start. There are many specific nutrients. I take omega-3 separately because I don't eat fish. I need to take extra omega-3 to make sure I'm getting enough of that. And it's the algae oil in a vegetarian capsule. For me personally, the average person can take the concentrated fish oil capsules and get more in there at a better price. But because of my restriction, I am restricted in what my options are as well. So, there are options I will recommend to people who do not share my dietary preferences that are more effective for them and would probably be more effective for me if I were willing to take them, frankly.
Of course.
But, because I'm making choices, I'm trying to compensate for those choices.
Thanks a lot for this informative answer.
Thank
you. Tawfiq, floor is you.
Thank you. Are there any questions coming in from the audience at all?
I think this meeting is really informative and it's okay.
Thank you.
Yes,
There's a question. Can you comment using zinc in COVID patients? Use of zinc.
Use of zinc. Oh, well, certainly. Zinc is something that has been widely used during the pandemic by consumers, and a lot of what they call complementary and alternative medicine physicians in the US are recommending them. The naturopaths and many of those folks. Zinc levels tend to get depleted with immune challenges, and zinc is something you'll find more in whole foods. You'll find it more in seafood, the certain types of foods. So depending on your diet, you might be more or less at risk of having low zinc levels. But zinc will be depleted by having an illness or an immune challenge like COVID. And it's not unusual that people will take a lot. Now, that said, the limit for zinc, if you're not getting copper with it, and copper and zinc have a relationship and that can interfere with each other. If you're getting more than about 100 milligrams a day for short term of zinc, say for 4 weeks or more, you really need to be looking at the copper levels. The Institute of Medicine in the United States has set 40 milligrams of copper a day as the limit for everyday use. And that has a wide margin because that 100 milligram is really the medical limit. In EU, the limit's 25 milligram for zinc per day. And that's, again, an even more conservative look at what would interfere with copper metabolism. But if you're getting a couple of milligrams of copper in a multivitamin or from eating copper-rich foods, again, a vegetarian diet is not rich in copper-containing foods. Red meat is. for example, or certain seafood. So depending on the diet, you might want to supplement a zinc with copper, and some supplements come like that already. Multivitamins will also come with both typically. Zinc lozenges, which are very popular when people are sick, do not typically have copper, but people are usually using them for a week or two and not long term. So that's okay too. But zinc is necessary for white blood cells, certain immune cells. It is used as part of the immune system's nutrient base, their backup.
One more question I want to add on, and you mentioned about the benefits of vitamin D for the insulin resistance, and all this concept of vitamin D importance. I personally noticed, the more studies coming in 2010 and onwards, and now we are looking at a figure like even by after a few years down the line. We are going to expect, in fact, doubling in the prevalence rate of diabetes in UAE, almost like the figures are showing like that. And there is one Finnish study you mentioned, 1966 onwards, following up on some group of patients, and then the outcome was quite good after so many years of follow-up. So, are we really missed the importance early regarding vitamin D? What's your
that is a good question. Well, there is a focus on making sure that pregnant women have adequate vitamin D, so they could pass it on to their children if they're nursing and breastfeeding. There's actually a program in the U.S. The Now Health group I'm with is partnering with Abbott Labs and some other companies to make a packet that goes to mothers who have just given birth in hospitals, and they get a packet to take home with them. And in that packet is a little bottle of vitamin D that been made by that has 100 units of vitamin D per drop in a dropper, and it's recommended to give that to the infant every day, to give 400 units, and that's something that's happening in American hospitals. So they recognize the importance of giving vitamin D to newborn infants, to making sure they have adequate amounts, as well as the prenatal care, where the mother gets a prenatal vitamin, which of course will have vitamin D in there. So vitamin D, I think the importance is becoming more and more recognized. If American hospitals and large pharmaceutical companies are involved in distributing vitamin D supplements to new mothers to give to the infants and making sure the mothers have it, that's pretty clear that they've seen the evidence, and it's starting to spread into the medical community more and more.
Just to add that to Hassan, that giving vitamin D to pregnant mothers and for planning pregnancy, it has even the GINA guidelines has mentioned that the early wheezing episodes can be reduced in newborn if you give vitamin D supplementation during that time.
Yeah, that Finnish study was 10,000 children. They were tracked till they were adults, and 78% lower risk of type 1 diabetes. I would think if somebody had a family history of diabetes and had a baby, they would want to make sure their baby was as well protected as possible. And one way would be to supplement a reasonable amount of vitamin D directly to the infant.
Yeah.
Cool.
There's one more question in the chat box. Vitamin B3 reduce metformin levels, and if then is it clinically important?
Which vitamin B3 did you say?
B3, vitamin B3.
So it's niacin or nicotinic acid.
Yeah.
Well, that is one of the B vitamins that is necessary for making glucose tolerance factor. So in order to control glucose in the body, you need adequate amounts of vitamin B3 niacin. So, it's clearly important. The U.S. Institute of Medicine recognizes that, and that's why it has a recommended daily allowance, because of that role. So I didn't talk about it in my presentation. It was some information on one slide that mentioned it, but the niacin B3 has an important role there, and as well as in lipid control. Obviously, with a short time frame, I can't talk about every nutrient for blood sugar. Cinnamon has some interesting studies. There's other nutrients as well.
Do you want to mention any Ayurvedic preparations which can be regularly used in?
Well, I think with the Ayurvedic, you're looking at Gymnema sylvestre as an Ayurvedic herb that's used to help control blood sugar. I like that very much. The anti-inflammatory things like curcumin, even holy basil has some anti-inflammatory roles in higher doses. So there's a number of those things. Ginger, that since inflammation and oxidation go hand in hand in the development of diabetes and the progression of diabetes, including neuropathies. Neuropathy, the damage is clearly oxidative and inflammatory. So having the ginger, turmeric, holy basil, those kind of things tend to be very important.
Dr. Hassan, you wanted to have any questions on asthma?
Dr. Oni, that's question for you.
Yeah.
Did you notice recently that after the COVID era, there is increasing number of patients that comes to the hospital with some symptoms or mimics just like asthma? Although you don't have any history of asthma before, even with tasting after spirometry and all, they are typical for asthma. Did you notice such cases?
This kind of, shortness of breath and, like irritant cough, which is persisting for long duration. This I have noticed. But with short duration of inhaled steroids, some of them are responding. I had very few patients, because most of the patients I listen to you, because you must be having more data on this. We do see some patients like this, but mostly they do respond with a short dose of inhaled steroids. And you notice something else in this management principle for these groups?
I think the same. Whatever you are doing is the same. Thank you, Dr. Oni. I think you was so informative and conclusive about all topics of asthma, from the basics to the advanced care of the patient. Dr. Neil also was, I think, a very interesting lecture. I think you can stay hours and hours more to ask about everything. As Dr. Magdi said, was asking you about some secrets you can give to us to improve our health or prolong life.
Yes.
Even if you can do that, even after the conversation, or you can give it to us only if you can. Thank you, Doctor.
Yes. Please feel free to contact me if you have any questions or concerns. I'm happy to share what I know.
Thanks a lot. Thanks a lot. Thank you, Dr. Oni. Thank you, Dr. Nel. Thank you.
Dr. Oni, any final comments from your side? Thank you, Tawfiq Kim. Thank you.
Thank you for giving us the opportunity once again with Zuleika Hospital. Thank you, Magdi. Thank you, Hassan. Dr. Neil, you are always there with us for all. I think this is the third time I think I have the opportunity to have a session with you. Thanks, Tawfiq, for giving the opportunity once again. And over to you, Tawfiq.
Thank you very much, Dr. Oni, for the great lecture, as well as Dr. Neil as always, like you are lightening us with your great knowledge of the nutrition. So thanks to all the
Thank you.
audience who stayed with us late night listening to us. So thank you, Dr. Hassan and Dr. Majdi, for moderating the session so beautifully. So let's take off now until we get together again with a new medicine update session soon. Thank you very much, all.
Thank you.
Thank you.
Thank you very much.
Thank you.
Good night, everyone.